we have another talk from Dr. Martin Dirisamer. He's going to talk us about evaluating patients for phakic IOLs.
Yeah. Hello again. So my talk, could you switch on the mic, please? Hello? Is it working? Yeah. So my talk is about focus on the ICL and some surgical purse probably. The history in phakic IOLs goes back to the 1950s, and probably some of you know some models which are shown here. I just know them from removal of some of them. But my personal journey or my personal experience is reduced to the Dirisamer, the ICL V4, the Cachet IOL, and the newest V4C ICL. So that's my choice of phakic IOLs. We only do ICLs. It was introduced in the 1990s. The material is Collamer, as you know. Meanwhile, there are more than 2 million implantations worldwide. And in our group, in our refractive group in Germany and Austria, we implanted more than 10,000 already. So the latest improvement, I think, was, or significant improvement, was the Aquaport, which is shown here, which reduced the complication of cataract significantly. So it's below 0.7% cataract after ICL right now. I think you all know the clinical outcomes, which are excellent. And if you look to PubMed, you find out that you have already more than 600 publications, and they're increasing dramatically. And I saw this yesterday, or the day before yesterday. It was in the Optometry Times, and the topic was EVO ICL may be the best kept secret in refractive surgery. I'm not sure whether it's a secret, but probably could be pushed even more. The percentage of ICL is increasing, at least in our clinic, so it almost one quarter of our refractive procedures are already ICL procedures. Why is that? What are the reasons for ICL growth? So it provides us with excellent results. The accuracy, stability, and efficacy is excellent. We have a very high patient satisfaction, very high surgeon satisfaction, excellent safety, no dry eye, quick rehabilitation, and no risk for ectasia. So the range of correction goes, according to the company, from minus 0.5 to minus 18 diopters, astigmatism up to 6 diopters, hyperopia up to 10 diopters. So the newer version shows an optical zone up to 6.1 millimeter, and this version and the toric version are now both FDA approved since March 2020. Patients who are not suitable for ICL, according to the official recommendation from STAR, from the company. By the way, I don't have any financial interest. The anterior chamber depth, smaller or shallower than 2.8 millimeter. Of course, any kind of concomitant eye diseases. But what I see, what is not mentioned here, the endothelial cell count. Of course, abnormalities of the endothelium, but also cell count should be at least 2,000. Any cataract makes sense, and the other things, I think it's pretty clear that if you have to deal with a glaucoma patient, you won't do in phakic IOL. So what about the sizing and vaulting? What we routinely do is we do 2 measurements, one with the IOL master and one with the pentacam. So the IOL master white-to-white measurement minus 0.3 millimeter. Then I compare it to the pentacam measurement, and the difference of both measurements should be not greater than 0.2 millimeter. If so, repeat the measurements. Probably dry, whatever, just repeat the measurements. So if we check up the patient the next day on a slit lamp, it's not really a measurement of the vault, but we get a kind of clinical impression how the ICL is located. But we have better options, of course. What we started with was the Scheimpflug, the pentacam imaging, which gives you a quantitative measurement of the vault. We do it routinely in 2 axes, so 90 and 180 degree, and check the vault in this axis. But it's way better to use an anterior segment OCT. Until now, only post-operative, but it gives you a very nice quantitative measurement, and it has a very high precision, probably most precise. Of course, it would be nice if you could also measure the wall intraoperatively. There, of course, the intraoperative OCT, you know them. There are studies out. Roger Salivar from Argentina, I think he's published something like intraoperative measurements, so where they really try to find the perfect position of the ICL to get the best volt. Some words about the lens loading. I think we can quickly go through this. We heard it's not complicated, so that's fine. It is like it's a very easy, straightforward procedure. Just keep in mind, lubricate the cartridge, use viscoelastic, and of course use the side ports for the manipulation of the ICL. There's a new protocol published by the company. They recommend a new type of paracentesis, so not the straight one, I show you the picture afterwards. Only use dispersive viscoelastic, so no cohesive viscoelastic. And they recommend only irrigation with cannula, so no need for a phakic machine or a tubing set. So it's cheaper. No myocol, no Nevanac, so just artificial tears post-operatively. That's the official protocol of company of STAR. So these are the paracenteses, so they're not like going straight and pointing to the center of the lens, but they are kind of tangential, so they're pointing to the periphery, which makes sense because the manipulation should not be centrally but peripherally. So it's the other way around with cataract surgery. So during the surgery, we heard already the leading right hole, so not the left one, so probably get confused now, but it's the right hole. Inject slowly until the leading right landmark is visible. And this is the official video, which was captured in Munich, how ICL implantation should be done. So the dispersive viscoelastic temporal incision, as you heard, it's 3.1 millimeter. Then inject slowly, and basically it's a very straightforward procedure. So just make sure that the haptics are behind the iris, and then you just can rinse the viscoelastic, so to irrigate the viscoelastic, so no need for a tubing set. And basically that's it. Probably you heard about the study Thomas Conant published where he used a cohesive viscoelastic and intensively tried to rinse the anterior chamber, and then he developed significantly cataract, so this might be not a good idea. Complications, I think you know all these complications, elevated IOP, cataract, and so on. Just want to point out the safety is very high, and the central port design may reduce the risk of cataract formation significantly, as I already told you. So some few words about the vaulting. An adequate vault range is from 90 to 1,000, so pretty large. The ideal vault range from 250 to 750 according to studies. Keep in mind the anatomy of the eye. So whereas we have a larger horizontal diameter in the cornea, it's the other way around in sulcus. So we can use this fact if we have to rotate the ICL because the vault is too high, for example. Of course, only in non-toric ICLs. I think that's clear. So this is a short video where it's showing a rotation, which is actually also pretty easy. Just be sure to use sufficient amount of viscoelastic, and then just rotate the IOL, and it's 90 degrees. And this is the post-op picture. The vault went down for 350 microns, so a significant reduction. As summary, ICL gives excellent visual results with low complication rate. The design and technique is still evolving. You heard about the multifocal ICL. I think it probably failed because the results are not very good, so more bad than good, but we will see. Some surgical person pitfalls, of course, it's intraocular surgery, so you have to keep that in mind. and the ICL enlarged the refractive surgery armamentarium. So it's additional to the laser vision correction, and yeah, gives us great results. Thank you very much.